Good evening to all the delegates and our eminent speakers. Thank you all for joining this evening. I am Siddhant Sharma on behalf of Hetero Healthcare. Welcome you all for the webinar on Introduction to Bempedoic Acid, Non-Statin Lipid-Lowering Agent in the Management of Uncontrolled LDLC. As you know, lifestyle disease in our country is on rise and it's surprisingly moving towards the chronic stage. We at Hetero Healthcare has always been at forefront along with your side to deal with such ailment. This evening, our esteemed speakers and esteemed and experienced doctors will share their experience on the subject. Before proceeding further, do let me take the privilege to introduce our eminent panelist. Dr. Pankaj Raut. He is a senior interventional cardiologist. He is a life member of Cardiological Society of India, Academy of Medical Sciences, Nagpur, and Association of Physicians of India. He has always been a part of well-renowned journals like Indian Heart Journal. He is a faculty in national and international conferences of interventional cardiology like Euro, PCR, PCT, ACC, and ESC. He has conducted more than 50 education programs and 75 cardiac camps across villages, towns, and cities in the Maharashtra. Also glad to introduce our second panelist, Dr. Sanjay Jain. A warm welcome to you on the Scientific Talk. He is a consultant physician at Shanti Mohan Hospital. He is a secretary of Diabetic Association of India, Nagpur in the year 2004-2005, and the president of Diabetic Association of India in the year 2010 and 11. He is a life member of Cardiological Society of India, Association of Physicians of India, ISCCM, that is Indian Society of Critical Care Medicine. He is also the president of Cardiological Society of India in Vidarbha chapter in the year 2005-2006. So I welcome Dr. Pankaj Raut, sir, and invite him to take over the session.
My screen is visible?
Yes, doctor.
Just a minute. It's not moving.
Yes, doctor, your screen is visible.
The slides are not moving.
Vijay, can you stop screen sharing and again we can do that?
Yeah. Okay. Now my screen is shared. Screen is visible?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Good evening, respected Jain sir and all esteemed my colleagues and teachers. Today we are going to discuss about the newer drug in anti-lipid management. So dyslipidemia is very important part of our day-to-day practice. Lipid management, dyslipidemia has major impact on cardiovascular mortality and morbidity. Burden of dyslipidemia on atherosclerotic cardiovascular disease is very high, and prevalence of dyslipidemia because around fewer guidelines has around 60% of people will have some dyslipidemia if they are tested after age of 50 years. So when we have dyslipidemia, the dyslipidemia is causing more prevalence of atherosclerosis. Atherosclerosis is leading to sudden cardiac death and stroke. So that's why desirable cholesterol level and maintaining cholesterol level below a desired standard desired level is important to prevention CV risk. Prevention and treatment of dyslipidemia is essential for cardiovascular risk modification. So individual in age of group of 30 to 40 years should have high prevalence of usually have high prevalence of dyslipidemia, and which increases once their age increases. So Indians are highly prone to develop atherosclerosis, cardiovascular disease at early age, which is 5 years younger. More MI, stroke, and other conditions which are causing high mortality. Two-thirds of the death due to non-communicable disease in India are caused by cardiovascular disease. And even in US or in Europe, the most common cause of mortality is still atherosclerosis, cardiovascular disease. So when we come to cholesterol level, so cholesterol level monitoring is very important. So cholesterol level should be total cholesterol level should be less than 170, and LDL cholesterol level, if patient is low risk, should be less than 100. If patient is having high risk, then cholesterol level should be managed very stringently, and it should be LDL cholesterol level should be less than 50. So, but still, when we are managing cholesterol level using anti-lipidemic agent, atorvastatin, rosuvastatin, ezetimibe, various drugs have come, but still will not receive, will be having some adverse event or some side effect of anti-lipidemic agent, or they will not achieve the target of LDL-C, and that's why there is more chances of atherosclerosis and more chances of events. What to do? What the guidelines say for uncontrolled LDL-C level? The LDL cholesterol is a key role in development of atherosclerotic plaque and subsequent cardiovascular event. Many patients with hypercholesterolemia remain above guideline recommended LDL-C threshold despite treatment of maximum tolerated statin. So that increases the risk of cardiovascular death and MI. So high cholesterol level not only choke your coronary arteries, but also it increases chances of stroke, also increases chances of renal failure. So during the cardiology, last 50 years of cardiology, most important thing which has developed is anti-lipidemic agent, which is decreasing the cardiovascular mortality, decreasing the MI and stroke. So there are various drugs are available for treatment of atorvastatin, rosuvastatin, which act in liver to remove cholesterol from the blood. Then there are cholesterol absorption inhibitor like ezetimibe, which limit absorption of dietary cholesterol. Then there are ACL inhibitors, which is bempedoic acid that inhibits the ACL enzyme and decreases the production of cholesterol, which is much higher level. Then there are bile acid sequestrant like cholesterolamine, which reduces the LDL cholesterol. Then PCSK9 inhibitor, these are antibody and can help liver to absorb more LDL cholesterol, and they significantly reduce the cholesterol level. Then there are phenofibrates and niacin and omega-3 fatty acid supplement. But statin, the other cholesterolic agents comes with some side effects, and like niacin or fibrates, which are having. So definitely that's why the research is going on muscles, because muscle soreness is most important side effect of statin. Statin, muscle soreness is most important important side effect. So this ACA is the cholesterol without much increasing side effect. So as per the cardiovascular drug and therapy guidelines to 21, up to 80% of patients treated with statin do not achieve LDL cholesterol level because of high baseline LDL level C and aggressive LDL C treatment goal. So lack of sufficient statin therapy and poor adherence because of side effects. So most common side effect is usually muscular symptom like muscle soreness or raise CKMB level, or even some patient may prone to develop myolysis. So challenges to what are the challenges in statin therapy? Statin is very important drug and they reduce the ASCVD risk by 15 to 37%, but that solely depend upon reduction of LDL-C cholesterol and also other pleiotropic effect. The residual ASCVD risk of 60 to 70% still persist despite optimal statin treatment. So definitely every trial has talked about the residual risk even after using maximally tolerated and antiplatelet agent, still there is residual risk and which is being talked in every trial. So non-attainment of LDL-C level is also important. Around 30 to 40% of patients of coronary artery disease, which are on secondary prevention, will not be able to achieve their LDL-C goal of less than 70, or when we say less than 50 is definitely impossible for few patients. And non-adherence of statin is also issue because of the primary myotoxicity or hepatotoxicity. So the challenges to statin is statin intolerance causing myolysis and muscle weakness, muscle soreness. So is much more needed. So that's why this newer drug is bempedoic acid is becoming very important for treatment of secondary prevention of atherosclerotic cardiovascular disease. The bempedoic acid is a drug used in conjugation with lifestyle modification, and it is also been approved with use of ezetimibe. So if we can use bempedoic acid and ezetimibe, it can decrease LDL cholesterol by 40% without using statin. Dose is 180 OD. Absorption, bempedoic acid is rapidly absorbed in small intestine and does not affected by food. It is acts 24-hour. Plasma binding is 99%. So definitely it will act longer. Bempedoic acid is reversibly converted to active metabolite. So bempedoic acid is converted to active metabolite and that inhibit this ACL enzyme. Excretion, urinary excretion is 70%, and remainder is excreted through feces. So even patient with liver dysfunction can be given bempedoic acid if they don't achieve their LDL goal. So where this works, bempedoic acid is usually converted into its active molecule. Inhibit the ACL convertase enzyme so that prevent acetyl coenzyme A to produce cholesterol in the Krebs cycle. And interestingly, bempedoic acid does not act on skeletal muscle, and muscle soreness is not a problem, not a big problem with the bempedoic acid. So this ACL-VL enzyme is expressed mainly in liver and kidneys, but not in skeletal muscle or other tissue. Liver or kidneys. So bempedoic acid, the activity of statin in muscle potentially contribute to statin-associated muscle symptoms that occur in some patients and resulting in poor treatment adherence and restricting use to low. So bempedoic acid has approved their first approval in February 2020 as monotherapy or in combination with ezetimibe as adjuvant to diet and maximally tolerated statin therapy in patients with familial hypercholesterolemia or established atherosclerotic disease. And bempedoic acid monotherapy can be tried, which can achieve LDL goal reduction of 43% and 41 definitely, and it reduces HSCR level by 40%. This is very interesting. It reduces HSCRP level, maybe inhibiting the inflammation going in atherosclerotic pack, and may be able to reduce the MACE or cardiovascular event or stroke events. Bempedoic acid with statin, reduction in LDL cholesterol by 22% and safe and effective along with statin therapy for additional lipid lowering. So what are the indications for bempedoic acid? Familial hypercholesterolemia, it has been class 1 indication. Any hypercholesterolemia indicated adjuvant and statin therapy for adult with familial disease who require additional lipid lowering agent to reduce their LDL-C target. Dose is 180 milligram per day. OD dosing. Drug interaction, definitely simvastatin and pravastatin with higher doses are associated with some muscle soreness with bempedoic acid and should be avoided. Pregnancy and lactation, this has not been studied well with bempedoic acid and should be avoided once pregnancy has been diagnosed. Adverse event, the adverse event are much lesser than statin, like upper respiratory tract infection, muscle spasm, uremia, back pain, abdominal pain, and anemia, and some elevated liver enzymes can be there. So hyperuricemia, elevation of serum uric acid level have been occurred in bempedoic acid patient, but which is periodically uric acid level should be checked and it is not significant. So what were the clinical trials? There are around 5 to 6 major clinical trials which has shown safety of bempedoic acid in prevention of atherosclerotic cardiovascular disease. This coming to this trial, Clear Serenity trial was most important conclusion was safety of bempedoic acid, and they have said that bempedoic acid has safe and well tolerated. Most common muscle-related adverse events were lesser compared to statins. Then Clear Harmony trial, which tested safety and efficacy, and they shown that they did not increase the adverse event when given along with the atorvastatin. And Clear Wisdom trial for 12 weeks when we use bempedoic acid. So, coming to conclusion, bempedoic acid is a novel lipid lowering agent inhibiting the ACL enzyme which present in the liver and kidney. It can be used an add-on therapy to maximally tolerated statin for desired LDL-C target. It reduces the apolipoprotein and high sensitivity C-reactive protein, and it is safer, doesn't cause a myalgia or minimal drug interaction. Thank you. Thanks a lot.
Dr. Sanjay, sir, can you share your thoughts and views on this?
He has already had a lucid presentation on the bempedoic acid. See, even if you give the, can you stop sharing the slide? It is a very well known fact. A few number of the patients are statin intolerant, particularly as he has already said, the muscle weakness. In fact, I've seen the patients who has gone up even to quadriparesis because of the statin induced myopathy. Recently, I've seen the pigment induced severe nephrotoxicity pigment-induced acute renal failure because of the dose, even just a 40 milligram atorvastatin. So it's mostly to do with the hypersensitivity. So we today I've seen the patient having a lot of itching with the statin. I've given re-challenge her same. So in that case, I think ezetimibe or bempedoic acid may be the bempedoic acid has a more potential than the ezetimibe. It can be combined with ezetimibe, but as he has already said, even after giving the statin full doses, there are considerable number of patients who are not able to achieve the target of LDL 70 or 50, which we want to achieve to prevent the further progression of the atherosclerosis. And we know the PCSK9 is beyond the reach of the so many, almost larger number of the population, and it's costly because of its cost and the injectable form. Though it's a very good molecule, but then I think bempedoic acid has come as a good rescue for that. And we should be using more and more bempedoic acid. We have started using that because we want to achieve, and it has already been proved, a good LDL control. I know you try to reach up to 70 or 50 because so many people are already having comorbidity in the form of diabetes, hypertension, and ISD. So I think it has got a great future, and it should be as the side effects profile is very, very, very minimal. And of course, it has to be. We are not no more using the simvastatin and pravastatin, so they are not to be combined with the bempedoic acid. Otherwise, it goes very well along. As somebody is asked, can we start the bempedoic acid straight away? It is possible in the statin intolerant patient, but as per the guidelines, we have to start statin first, and then if it is not controlled, not able to achieve the target, we add on the bempedoic acids or along with ezetimibe and other things. And as he has already said, the niacin and other things are is really intolerable, and they are very diabetogenic. Even the rosuvastatin, although the minimal patient turn into diabetic maybe 0.9%, but there are studies maybe a bit more. So I think in those cases, bempedoic acid has a definite role, and as we will start using more and more, I think we will be in a better position to comment on that.
Thank you, Doctor, for the closing remarks. There are a few question and answers which is on the chat box. Dr. Pankaj, there are questions on the chat box.
How many percent of patients observed having uncontrolled cholesterol level and can be given as a monotherapy? After using statin, there are around 10-20% of patients will not achieve desired LDL-C cholesterol reduction. So bempedoic acid can be used as an add-on. And if patient is having statin intolerance, we can use bempedoic acid as a monotherapy or along with ezetimibe.
Okay. So in diabetic perspective also, there are questions like how many percent of patients observed having uncontrolled LDL-C levels. Again, in diabetic patient also, can we start using bempedoic acid? That is what the question is.
I think the uncontrolled diabetes is more of a triglyceridemia. Of course, if the patient is already having hypercholesterolemia or familial hypercholesterol, that is different issue. But otherwise, uncontrolled diabetes is more of a hypertriglyceridemia, which tends to get controlled with the control of diabetes. And there are drugs like saroglitazar to control the hypertriglyceridemia. But in that case, also, as I've said, it applies to everybody. We have to bring the cholesterol to with the comorbidity to 70 or less than 70, we can always take the help of the bempedoic acid, which is quite safe drug and it is quite effective drug. I think that there is a definite role of the bempedoic acid in the post-diabetes, and any post-court complications in the lipid profile, I have not seen any alteration in the lipid profile post-COVID. Pankaj, you may have to say something.
No, sir. Thrombotic tendencies are more, but lipid, I don't think.
Because we have treated extensively COVID patients, but no change in the lipids as such. We have observed it may be the same as earlier, which was there. Some lot of drugs have been given, but lipid was never a priority in the COVID. It is always the respiratory and other complications secondary to the drugs.
Okay. So I think we had this question. So yes, doctor, thank you so much. It was indeed a pleasure and an honor having you doing this webinar. We, on the behalf of Hetero Healthcare, we would like to extend our sincere thanks to you for your comprehensive session, and we are sure our delegates would have got enlightened regarding the molecule as we have covered all the possible aspects in our session. Also, I would like to extend our thanks to all the delegates for their warm presence. Thank you so much for joining, Doctor.
Thank you.
Thank you. Bye, sir. Bye, Dr. Pankaj. Bye, Dr. Jain.
Thank you, sir.